patients who would, who could sue us or who could take us to task if we would not use molecular tools to diagnose them or at least assist us in making correct diagnosis. Just to share with you, around say 2 months back or 3 months back, we had a lady who was a thalassomic carrier. She went to a proper physician and she said that I am a carrier, and the physician said, don't worry, when you will be pregnant, at that time inform your gynecologist, then she will draw a sample from your abdomen and they will test it for thalassemia. Unluckily, they didn't even look for the genetic markers of thalassemia in that lady, and when that lady went to the obstetrician, it took them number of days. It took them around 1 month, and still they could not locate the molecular reason for thalassemia. So even when a person has to do general practice, he has to be well aware when to order which test. These are the other areas where molecular diagnostics would be helpful. Long back when we did study, this is all what we had. Now a microscope has become this big. It has all the armature attached to it. When we talked about genetics, most of us think genetics is synonymous with inherited disorders, and most of us think genetics means it is an inherited disorder and nothing can be done. And except for Downs, nothing else comes to our mind. But as time evolves, we can also use the knowledge of genetics for treatment of just not treatment or identification of not genetic disorders, but even acquired disorders. I would focus my next 10 minutes on a technology which is very commonly used for helping fetal medicine people, for helping IVF people, and for helping cancer physicians to diagnose and treat patients more appropriately. This is fluorescent in situ hybridization, and I think this is available in Delhi at around 4 or 5 places, and it has a great implication in our day-to-day lives. This is what it is. It looks very simple. All of us know that we are made up of cells, and cells have chromosomes in them. But most of the time, if we want to do something like a karyotype, we need cells dividing. In fluorescent in situ hybridization, you can do these tests even with non-dividing cells. It's a great advantage. There is a short turnaround time, so you can test it fast. It can be performed on an interface cell, that means a non-dividing cell, and less manual intervention is required. This supposes one chromosome, and this is its complementary chromosome. And most of the chromosomes, if you want to do a fish, you will have a control signal, which is a fluorescent signal, and there is a region of interest which we can label. To cite you an example, all of us have heard of amniocentesis, and nowadays most of the gynae obs people would send the pregnant females for something known as a triple test and sometimes a dual test. And the triple test is a general indicator of the level of risk the lady has to have an abnormal child. If the risk is quite high, the obstetrician or the gynecologist can ask for an amniocentesis. And is it too loud? Okay, sorry. So when the obstetrician or the gynecologist asks for a test, they would put a small needle there and take out, say, around 10 ml of amniotic fluid. You could spin that amniotic fluid and stain these cells. This is a single cell, and these are two signals. This is chromosome 21 and this is, say, 18. So if the signals are two signals for each chromosome, you would think that this is a normal cell. But since this person has 1, 2 and 3 signals, this indicates that this lady could be pregnant with a child who is a Down syndrome child, and the turnaround time is just 3 days. So it's a great advantage and great technology with lot of accuracy and good sensitivity. We could have used a normal karyotype, But this is not just more time consuming, it also has some disadvantage in that many times that the culture, if doesn't perform, you would not be able to put a proper diagnosis on that female. Another area where fish is used is blood cancers, leukemias and solid tumors. When we were in medical school, we would say if there is a huge TLC count, you would presume that this person has a CML as long as he would have a spleen. If you could see some premature cells, you would again presume that this person has CML. Then came an era where you would say that this is CML if you are able to have an ABL-BCR translocation in a karyotype. So this is a very cumbersome method of doing this. This is a normal cell and this is a translocate. And if you have this, you would be able to, identify this person as a CML patient. And as soon as you start treating him, these kind of cells, if they disappear from the peripheral smear or from the marrow, you would presume that this person is getting cured. So again, this is a good use of this fluorescent in situ hybridization technology towards the treatment of CML patients. Again, if you see an abnormal kind of a signal, you would think that the drug is not working. This is a very typical, the first example of molecular medicine. There is a particular drug, imatinib or Gleevec, which acts just here. And I think now in the last 10 years, we have at least 10 molecular drugs which are very specific. And in the coming days, you may have hundreds or thousands or tens of thousands. And soon a time will come when most of our drugs will be based on molecules which are very specific, which are very targeted. And if you ever have come across a patient of CML who is being treated by imatinib, you will see that there is no hair loss, there is no side effects, there is no effect of chemotherapy. So this is the advantage of this technology. Again, there is another example of a typical 12-21 translocation in an acute lymphocytic leukemia. All of us knew in our medical school that ALL in children has good prognosis. At the same time, we also know that some of these children do not do well. Now we have proof in terms of molecular tools which are these children of ALL who will do well and which are the children who will not do well. So if a pediatric hematologist has access to this, he would be able to tell the patient in time, the family in time, that it's worth selling your house, selling your stuff, treat this child, it's curable because of this good prognostic marker. Again, if you have a poor prognostic marker, this is a break apart signal, this is a chromosome MLL gene which is on chromosome 11. Now if this is there, then probably even when you put your level best efforts, this child may not do well. Similarly, this is I think the next molecular medicine which came into existence was for AML-M3. I remember around 10-15 years back, AML-M3 had a very poor prognosis. Almost every third person with AML-M3 would bleed and they would die. And there was a quack or a self-styled physician somewhere in Dehradun. He would treat them with arsenic, and many of them would get all right, and some of them would die because of arsenic. And after a couple of years, they reported that Atra is a very good molecule which works on AML-M3. And if you have a patient of AML-M3 and he has A21 translocation positive, he is bound to get all right, and the cure rates are beyond 90%. Again, this is again a marker in MDS. Lots of times you have around patients in age group of 50 and 60 and they have anemia, and we are not able to know what is the cause of anemia. And you keep on looking for things, even their karyotypes are normal, till you finally discover that there is a loss of